Hello, folks. Good afternoon, and welcome to our webinar on the best evidence use of simulation in your curriculum, featuring Harvey and UMedic. We're glad that so many people were able to join us. My name is Ross Scalise. I am Associate Professor of Medicine here at the University of Miami Miller School of Medicine. And at the Gordon Center for Research in Medical Education, I am the Director of Educational Technology Development. My colleague.
Good morning, everybody. I'm Hector Rivera. I'm an internal medicine physician by training, and at the University of Miami Miller School of Medicine, I am an assistant professor of medicine, and at the Gordon Center, I am the assistant director for curriculum and technology development.
And we're really pleased that so many people have been able to join us. We see now we're almost 250 participants. That's terrific. We have a few housekeeping items related to how we're going to conduct the webinar.
Okay. The first is that all the microphones from the participants will be muted automatically in this video conference session or webinar. If you are having any technical issues or would like to communicate with other participants in the webinar, please use the live chat option that is at the bottom of your screen. For any questions that you would like to ask us as panelists, please do so through the Q&A, and we will have either two options to responding live, or we will text you the answer to that question. As a matter of fact, one of the questions has already come up in the Q&A, and it is regarding if it is possible to obtain the slides of this presentation. And the answer that we would like to provide to that is that within a week after this session, you will receive a link to view the webinar at a later time, and you will have this available to you, to all participants.
Okay. So let's get back to our slides.
Okay.
And you've heard just very brief introductions of ourselves, but we would like to know a little bit more about the audience out there.
Absolutely. So we've looked at the pre-registration list, but we wanted to ask you a question of those that are actually present today. Who are you? Who do you identify yourself as? A physician, nurse, physician assistant, basic scientist, educational specialist, technology simulation specialist, or other? Okay, very good. So we have 48% of you are nursing, 22% educational specialist, 15% technology simulation, 4% physicians, and other identified as 11% in this polling.
Okay. So we have, now we know who you are. We'd like to know who is it that you teach?
So medical students, nursing students, physician assistants, and you can see the rest of the list there.
Yeah, so sorry that we didn't list all allied health professions in the previous slide. We see we have some respiratory therapists, paramedics. Great that we have this interprofessional group joining us. Sorry to lump those folks into the other category.
Okay, very well. We have about 53% are focused on nursing students, 13% other health professional students, 3% resident physician and fellows, 2% advanced practice nurses, and 23% practicing health professionals, and medical students about 5%.
And we realize that some of you maybe teach multiple groups of learners, or but so just try to get a rough idea, maybe how you spend the majority of your time. We have one more question. Since we are going to be using Harvey and UMedic as examples throughout the session today, we're just curious how many people have past experience, current experience, either for teaching or assessment, or thinking about using Harvey. Especially interested, you may have experience as a teacher and as a learner, but for those of you who actually been on the learning side of using Harvey or UMedic, we see that we do have some people. Okay.
So as you can see the results on your screen, 70% are thinking about future use, About 5% have had past use, current use for teaching about 12%, current use for assessment 2%, and any experience as a learner about 11% of the participants. Okay, very good.
All right, so that's very helpful to know. And for the large majority of you who are maybe looking for a little bit more information about using Harvey and UMedic, hopefully we can answer some of those questions during this. Having said that, these educational systems are have been developed and are distributed from the University of Miami. So both Hector and I have a lot of experience using them in our educational practice. That's part of the reason that we're going to cite them frequently as examples to illustrate the educational principles we'll be talking about. In addition, because Harvey's been around nearly 50 years, it's probably one of the best studied simulators. So there's a lot of research evidence out there to support some of the notions that we're going to be speaking about with you. However, despite the fact that we are going to be talking about these educational products, if you will, you should know that Hector and I don't receive any commission for selling Harveys. In fact, this is a not-for-profit enterprise of the university. Similarly, if we mention any other specific simulation systems, we do not have any interests in those entities. Laerdal Medical is our distributor for Harvey in many parts of the world, but again, we do not have any fiduciary relationship with them. We would, however, like to acknowledge their support for sponsoring the platform for this webinar today. Our objectives for the session are before you. We'd like to describe what we think are the features of simulation that will lead to effective learning. And we will share with you some of these which are evidence-based principles to help you to maximize the educational outcomes that you can achieve. And along the way, we will talk about how you can use an evidence-based systematic approach for using Harvey and UMedic in your training programs. We would like to start by remembering our founding director, Dr. Michael Gordon. He is well known as the inventor of Harvey, but perhaps not as well known that he was also a pioneer, having developed some of the first e-learning programs in health professions education. He was also one of the very first people to fully embrace the notion of interprofessional education, which has become so widespread currently. Dr. Gordon passed away this past summer at the age of 80. And we're always very mindful of his legacy and the example that he set for us. This is the center that he founded and which bears his name. I'm frequently giving tours for people visiting our center, and if you walk through the entranceway here and you look up above, we have our mission statement right there for everyone to see: saving lives through simulation technology. I try to always keep that in the forefront of my thinking, because Dr. Gordon always said, you know, simulation or any educational technology, that's just a tool, a means to an end, not an end unto itself. What we're really trying to do by using these techniques is to improve our training. And if we turn out better clinicians, better practitioners, then we hope that they'll be taking better care of patients. And that's the saving lives part, which is really our main focus. I also tell people when they visit our center, don't be intimidated. The fact that we have 2 stories and 3,400 square feet, a state-of-the-art facility here, it didn't start that way. Dr. Gordon often tells the story how he shared an office with Harvey behind the dog lab here at the medical school when he first was getting started. So you do not need a multi-million-dollar simulation facility or every conceivable type of simulator to have high quality and effective educational programs. It's really about how you use the tools by applying fundamental educational principles. And those are what we're going to try to share with you today. Although we're going to be citing Harvey quite frequently throughout this hour, what we're going to talk about would apply really to any type of simulation. And here you can kind of see some photos showing the gamut. Some of you may be using, full body type of mannequins, like in this upper left panel. You may be doing your simulation in realistic field settings or in situ simulation, in situ simulation. Some of you may be more in the clinical skills center setting, like this middle photo, using more standardized patients. Similarly, though, you can get effective educational outcomes from purely virtual, screen-based type of simulations like you see here, or combinations where we have virtual reality, or this one showing endotracheal intubation has a task trainer with augmented virtual reality images superimposed. Another combination of simulation modalities you may be aware of, what we call hybrid simulations. In this panel here, this series of photos, we have a task trainer, which is called the cut suit, which is actually worn by a standardized patient. And so you can leverage many different types of simulation modalities. The key is trying to implement the effective features or uses of those simulation to achieve your educational outcomes. So what is the evidence out there that's going to back up these educational principles that we're going to talk about? Well, much of it comes from a systematic review that we did a number of years ago under the auspices of the BEME collaboration. BEME stands for Best Evidence Medical Education. I'm just curious, how many of you have heard of BEME before today? So we'll just have a very quick poll, simple yes or no answer, just to get an idea. And that's pretty much as I would have anticipated. With the majority of you having answered, we can see that most of you have not. A small majority have, and that's great. And hopefully we'll let you know a little bit more about BEME. Those of you who hadn't heard of BEME before, I bet you have heard about evidence-based medicine, EBM, or evidence-based practice, right? BEME would be the educational analog to the clinical EBM or EBP. So the BEME collaboration would be much like the Cochrane collaboration. So a group of individuals and academic institutions that are committed to promoting or finding, uncovering the best evidence available to inform decision-making. In this case, not in our clinical practices, but in our educational practices. And the BEME Executive Board, almost 20 years ago, commissioned a series of reviews on hot topics at the time. This was in the late 90s, very beginning of 2000. And because of our long experience, this was the time when simulation was really on the upswing worldwide. And because the Gordon Center had probably the longest experience using these tools, they asked us to lead a systematic review to answer this question. What are the features or uses of high fidelity simulation that lead to effective learning? It wasn't to try to see simulation better or as good as or inferior to other teaching modalities. Because so many people were using it, they said, okay, if we're going to be using simulation, let's find what are the best uses of this technique. We published the results of this systematic review in 2005 in Medical Teacher. The reference is here for you. I'm proud to say that this has become the most cited reference related to simulation-based health professions education. It covered a review period of 34 years from 1969 till mid-2003 when we decided to end our search. We uncovered almost 700 journal articles and more than 2,000 potential abstracts. And using our inclusion criteria, we whittled that down to a group of articles and references, 109 of them. Notably, these were all positive studies. So one of the inclusion criteria was that these studies had to show that some learning did occur. And then in an iterative process, we tried to distill those features. What were the things they talked about in all of these articles that seemed to contribute to the positive learning that happened? And here they're listed for you. Many of these things will not come as a surprise, like the provision of feedback, opportunities for repetitive practice, etc. And we will talk about these each in detail. These were the top 10 most frequently cited features of simulation. A number of years later, Yvette Motola, who's the assistant director of the Gordon Center now, Barry Eisenberg is our center director, some of our former international research fellows, they put together this AMI guide, which essentially fleshed out the BIMI features. They went back to the literature and got some more recent illustrative examples of those features and tried to explain how we can best use these different and implement these features of simulation in our training programs. So the first list had them in order of the frequency with which they were cited in those articles. This list, I think, takes a little bit more stepwise approach and starts with what I think is probably the first feature that we must consider when we're using simulation if we want to get effective learning, and that's defining our outcomes. We'll go through each of these sequentially, but this is the first one. And I started with that one because as I travel around the world visiting various simulation programs, I encounter lots of places that go out and they build their facility, and they buy a lot of mannequins, and they say, okay, now what are we going to do with this, with these training resources? But that's kind of a backward approach to go and get the simulators first without having first defined what are the outcomes that we're trying to achieve. So as this cartoon illustrates, it's kind of a classic example of putting the cart before the horse. It's really critically important that we define and later ultimately measure our outcomes up front. You want to ask yourself, what are we trying to achieve with our simulation program? That may be an outcome related to your specific course. Maybe you're teaching in an undergraduate nursing program or a physician assistant training program, medical school, residency. Maybe you're trying to accomplish outcomes related to your overall curricular goals or things that your whole institution does. Sometimes there are higher order outcomes that we're trying to achieve related to regulatory requirements, like if you're in nursing, the CCNE, or in medicine, the LCME requirements, milestones from the ACGME, and so forth. But it's very important that you characterize or define upfront what are the outcomes you're trying to achieve. Later, of course, in this competency-based model, you need to actually assess whether we have achieved the outcomes, and that's where the measurement comes in.
As we further look into integrating the simulation into your curriculum, it is very important to have protected time for individuals. It should not be an option or something that is just used for fun as a teaching modality or an assessment modality. Some examples of this we've seen throughout the years. One example that we could highlight has been the use of Harvey in the UK. The British Foundation some years ago purchased a Harvey for each one of the medical schools, and later on went back and did a survey to take a look at how each institution was actually using Harvey in their programs. Some felt that it was that had such a high cost that really didn't use it and actually framed them behind some glass or in a way that nobody could access to the simulator. Others went ahead and incorporated the simulator into their curriculum and looked at testing outcomes and look at tracking the use of the different learners and seeing that the great results that they had by doing this. Some recent examples also, we have our cardiology program. There was a lot of interest in obtaining a virtual reality cath simulator, which has great features and many can learn much from it. And we've seen how not implementing in the curricula or creating protected time or educational time for the fellows can deter in the use of this type of simulator. So it's very important overall to track the learner's usage, to track outcomes or test outcomes, and to go and to make sure that you have a good blueprinting of what you actually want to accomplish. If you look back at our March 2017 webinar that we did, we covered this topic in great extent, so you can use that as a basis for this webinar. As we go forward, we can see that Harvey comes with different types of learner manuals and curriculum, focusing for different types of learner populations. And we have instructor guides as well. And in each one of these instructor guides, we actually provide key frames as to how you can implement Harvey and UMedic in your programs. This is an example for the nursing school where we have a more basic assessment and more of an advanced assessment in the second year, and each one is focusing on different things. The first year, you'll have more normal cardiovascular physiology and bedside examination, just being able to differentiate what's normal from abnormal, and it creates that basis, and how you can accomplish these in the different types of courses, modules, courses here for physiology, modules introductory normal on Harvey, and the type of methods or individualized learning strategies that you can use, such as large group, lecture setting, small group, or independent learning, and the amount of time it would be required to be able to accomplish these. You can see that within that level 1 or basic, you also have coronary artery disease and some murmurs and pathophysiology that they would actually go over in that course, and that would be their learning goals or objectives. And we would do this by looking at pathophysiology, clinical skills, and simulation centers. And the different modules that you would have would be angina, anterior infarction, and repeating those that were above so they can see the difference between normal and abnormal and highlight. Again, the individualized learning strategies, you can see large group and small group sessions and independent learning, and the amount of hours that they would take. Similar model for the second year, but now you would look at more review of common murmurs, including bedside examination, pathophysiology, and nursing interventions, and this would be usually done at the simulation center. These would, as far as the modules, we have diverse patient scenarios that are pre-programmed within Harvey that they could use, using small group independent learning and the amount of hours that they would actually use. Okay. And these are more common findings that individuals would see in different types of patients. So this is an example for medical school training. And one thing I would like to say before we do this is an example for graduate entry that we have here in North America. But in some other countries, you might have undergraduate entry where year 1 might be the equivalent of the 3rd year of your programs. Looking at this example for graduate entry, we can see that in year 1, we would focus more on normal cardiovascular pathophysiology. And this is more of a vertically integrated throughout all the years of medical school. In that first year, you would focus more on physiology and early clinical skills of the students using the normal modules. The methods would typically be large group settings and small group and independent learning, and the amount of hours that you would take, you could see there on the side. Now, this can also vary because the amount of independent learning and the access that the students might have might help each one achieve those levels at their own pace. A year 2, now we look at review of normal and classic valve lesions and pathophysiology. And so in the course, you would be focusing on pathophysiology and advanced clinical skills. And as far as the modules, we have different types of patient scenarios already pre-programmed in Harvey, as mentioned before. And you would use large group lecture settings, small group, and independent learning, and roughly about 8 hours overall to be able to accomplish these. In the 3rd year, the students advance, now they're in the medicine clerkship. You want them not only to be able to correlate the physiology, pathophysiology, and review common bedside diseases, but also kind of correlate all the examination, laboratory evaluation, and treatment for each one of these patient scenarios. They could do this through a small group and independent learning, and it would take them approximately 7.5 hours. And more advanced learners might require more independent learning, as you can see, as you go and advance throughout the years in this vertical integrated model, and require probably most likely less instructor time. Now for year 4, if you look at this comprehensive review of cardiovascular curriculum, now you're in the adult and or pediatric electives, and you review all the previous ones, and you have small group and independent learning and about 15 to 20 hours in a 4-week elective. Now what we're gonna show you next is actually an example of a 1 week that is part of our 4-week cardiovascular curriculum that we have here at the Gordon Center, where we have medical students coming through. A lot of times we'll have our residents coming through this as well for family and internal medicine. And I want you to focus on a couple of things here. One is the yellow spots, which is CPS rounds, and basically it's the use of the simulator within those main lectures. So it's a teacher or instructor-led sessions, and which comprise about 1/3 of the bedside skills that we're teaching them. And if you notice also in the white, you'll see the independent learning strategies that we're using, where the students will actually go ahead and use UMedic and Harvey at an independent pace and in small group sessions, and that comprises about 2/3 of our bedside skills examination, training, and learning. So the idea is that we want to have adaptable multiple learning strategies to all, and by doing that, or to do this, we use large group instructor teaching, small group instructor teaching, students, in some cases, near peers. For example, there would be the second year students teaching the first year students in small group sessions, and small group independent learning, where the students would go in groups typically no greater than 6. Is what we like to keep here for small group sessions, and individual self-learning, because ultimately each one will learn at a different pace. So to be able to do this, we provide individualized learning strategies, where you can see here in the upper left, one of our faculty members, Dr. Esterson, teaching to our students in the classroom doing the bedside skills examination. A small group session where you can see on the right upper corner, a faculty member from nursing teaching their nursing school students. And you can see here more of a peer group or a small group session on the left lower corner using Harvey. And if you notice in the background, using the UMedic programs, and which I'll talk more about in a few seconds. And here you can see on the right bottom corner, more an individualized or an individual learning session. When using UMedic, and one of the reasons we use UMedic and created UMedic is because it provides a very comprehensive curriculum where you can see history in the upper tabs of it, cardiac exam, diagnosis, summary, labs, treatment, pathophysiology, some additional commentary, and some closing comments at the end. This allows us to standardize a lot of the education we do, and not only standardize it, but it also reduces the amount of time that faculty would be needed to be at the bedside to be able to teach a lot of these different clinical and bedside examinations. So I'm going to play a little example of how we would use this. So if we're using it with the setting with Harvey, there would be a question that would come up and say, please go to the bedside of Harvey. In this case, we're going to be using aortic stenosis, so it would be pre-programmed already in Harvey in number 13, patient scenario number 13. And the student would go ahead and examine the right upper sternal edge or right upper sternal border. They would go ahead and auscultate in that area, and then they would be asked to go ahead and provide comments as to what they felt they heard. So in that area. So if the student picks the incorrect answer, it would provide immediate feedback to them and say, your answer is incorrect. Your answer refers to a long, late, peaking crescendo. Our patient is a long, late, peaking crescendo, decrescendo murmur. And in your case, this is what you're hearing. So I'm going to put a little bit of volume here so you can hear it there. And you can hear that whole systolic murmur, which is very different. So you can contrast between both of these. Okay. Immediately after that, further discussion would be provided, and as you can see on our faculty members, in this case, Dr. Michael Gordon, would come here and would provide further explanation of the case. And this would be, for example, one of 14 further explanations and discussions that the student would be able to obtain in that case. But let's say if the student actually picked the correct answer, as it will be demonstrated here, they would be asked to go and examine the bedside for Harvey. They would come back and pick the appropriate answer, which would be long, late, peaking crescendo, decrescendo murmur for the aortic stenosis in the aortic area. And in this case, the students would actually have two options. Either they could proceed and continue, so they would be able to go through these programs at their own pace because it might take some longer or some shorter amount of time, or they can further amplify in discussions about these. One of the things that we've seen the students do with these programs is that many times they'll go back to the different questions, and so they can get all the differential diagnosis for each one of these. And with this, they get to see a big variety of cases. So when we look at individualized active learning, there was a study that was done some years ago where they looked at just implementing a simulator into a program which was instructor-led, and which that showed that it didn't really provide much of a significant outcome in the teaching or the improvement of the skills of the students, showing that one of the key features is actually providing individualized learning and allowing a lot of the students to be able to go back and train at their own pace. Because the pace at which each learner progresses to higher levels of difficulty are actually set by each one of the learners and not by the instructors themselves.
Yeah, one of the things, that's important, sometimes people think that, simulation is automatically very active, right? Because it's very hands-on. But if you're doing large group instructor-led type of simulation activities, you have to take a little bit of extra effort to incorporate some things which will keep it as an active learning process. If the instructor is up in front of the room saying, does everybody hear this S4, this fourth heart sound? Everybody will nod yes, or they'll be checking their smartphones and things like that. So doing simple things like an audience response system or calling on individuals, having them come up and ask, how do you feel this precordial impulse, etc. You want to make sure that you incorporate active learning techniques. So simulation isn't automatically active unless you build that into your instructional design.
Okay. So as we look at scenario level to learner, it's very important to match these with the appropriate learner level. And if we look at this example that we have here, you can see at the level 1, the first year medical student that we identified previously, their task is more identifying the sound. So in this case, it would look at identifying, can they hear the fourth heart sound? Can they hear a third heart sound or a second heart sound? At the level 2, second year medical student in this case, are they able to correlate the finding with the pathophysiology or the physiology? This fourth heart sound in this case is caused by an increased afterload of the left ventricle. In the third level, now we look at the third year medical student, for example, and see that the task for them in particular is generated differential diagnosis and being able to differentiate one from another and what is the possible causes of the aortic stenosis in this patient, the hypertension, and other examples that could come up. Now, if we look at a level 4, in this case, we're looking more at the second year internal medicine resident, where now we're looking at their decision capability. What are they going to do? Once they've identified all these associated with pathophysiology, what exactly are they going to do for this patient? Are they going to order an EKG? Are they going to consult with a specialist? What's the initial medical therapy that they're going to provide? And as a matter of fact, Harvey comes with 50 pre-programmed patient scenarios that it can simulate, but you would use these at the appropriate level of each one of the students. Typically, for example, we won't show tetralogy for load to our students unless it's pertinent to their pediatric rotations, and we would commonly show this to our cardiology fellows. Here you can see the design variety of patient scenarios is extremely important, where it also helps us standardize a lot of the programs, as we can see that healthcare has changed throughout the years and the length of stay of many of our patients is reduced, and the possibility to be exposed to a lot of different varieties of certain conditions is reduced as well. So having simulators that allow us to provide that variation of patient scenarios is important because it allows us to standardize the programs in many ways. And it also makes learning generalizable of the different skills. In addition, you can see, for example, here, this is a study that was done, and it was represented in one of the AMI guides, where they looked at intubation and they looked at different scenarios, and they started off with more basic scenarios of obtaining the intubation and proceeding to more increasing difficulty scenarios, where now they would have to do things as cervical immobilization, or where they would be confronted with trismus in a patient that was simulated and try to intubate that, pharyngeal obstruction, laryngospasm, tongue edema. And as one side note, as something that we've used in the past and we continue to use in our center, is the Laerdal SimMan 3G or Laerdal SimMan simulators, which have many of these capabilities, and you can make intubations more difficult. They have the cervical immobilization palpitations, the tongue edema, laryngospasms, all these different things that they're able to do. So one of the great features about our simulation settings, as many of you know that have been using simulation throughout the years now, is one, it's become a safe environment where the learners can actually have an opportunity to learn, and it's more of a focus on learning on the students and providing these ideal situations where you can focus on the student and not the patient itself. And we have the ability to be able to stop any scenario at any point in time to provide any needed or additional feedback at those points. It also allows us to recognize and correct or avoid any mistakes that could be transferable to real patients that the students could commit. So it allows us to be able to recognize a lot of great things in the students and make sure that they provide the best of care later on to each one of our patients. Okay.
All right, so we're coming to the end of our list of important features to incorporate into our simulation educational practice. One of them, which is fairly intuitive, is that in the simulation setting, we can offer opportunities for repetitive practice of skills. Especially if we're talking about psychomotor type of skills, muscle memory, quote unquote, is something that can be learned. But this notion of practice opportunities is more than just achieving automaticity with psychomotor skills. And in a more fleshed out framework, rather than just doing a certain task over and over again, if there's certain reflection on the performance and feedback given, what we call deliberate practice, that can yield even greater learning outcomes. And I'm going to talk about that when we put this all together at the end. How much practice is often a question that is asked. How many times does someone have to repeat? Well, you know, it's been a quota system for many years in our health professions education, but we're moving away from that because we realize that every individual learns at a different rate. Ideally, the amount of practice time would be defined by the learner. Now, if we adopt this type of model, and we're going to talk about this more at the end when we talk about mastery learning, this has implications for curriculum planners. If the learner says, I need to practice more, then we have to, as the educators, we have to think about how can we make the simulations available for them to get the practice that they want. Things like off-hours access to the simulation center. And so there are logistical challenges, but some research has shown that these can be overcome and that it is doable to have a learner-centric approach to how much practice. In any case, though, we know from the evidence that the more you practice, especially if you practice well, again, that's what we'll talk about, deliberate practice, the more you learn. This article that I have here shown with the reference beneath it, Bill McGahey was the first author, was a sub-analysis of our larger BME review. There were 31 out of the 109 included articles that had enough detail in their data that we could see how long were the training sessions or how much practice was afforded to those learners. And as you can see here, the relationship was approximately a dose-response type of relationship. In other words, when they did more practice, they learned more. And there was actually a clear separation between shorter type of educational interventions, those things that were only a half a day or less versus things that were 8 hours or more. So more than a one-day training in aggregate led to the best learning outcomes. Another study that was done with Harvey and UMedic demonstrates similar results. In this study, we had fourth-year medical students at the University of Miami, UM. We had a comparison group of fourth-year, final-year students at non-University of Miami medical schools in the US. And we also did some training with residents in internal medicine. PGY stands for postgraduate year 2 and 3, internal medicine residents. At baseline, before there was any education done, they scored quite similarly, no statistical difference on a pretest. But then we gave our group of fourth-year students and our residents a training intervention that incorporated Harvey and UMedic. The students at other schools did their traditional cardiology elective, which was primarily based on the clinical wards and clinics. Then we post-tested them. This was a 1-month experience, a 1-month elective in cardiology. And you could see that the UM students and residents significantly outperformed the control group students who actually did not statistically improve their performance. Both of these groups nearly doubled their scores on a post-test. And another important thing that came out, if you notice, there was a trend, although it wasn't statistically significantly different, there was a trend toward fourth-year medical students actually outperforming senior residents. They actually have more clinical experience, but focused repetitive practice. The medical students on average practiced for 16 hours versus the residents who were only 10 hours of practice. They almost performed better than the residents. So it shows that the amount of practice is a very important indicator or factor leading to learning outcomes. And finally, probably the greatest effect on learning is from the use of feedback in our simulation training. This, I think, will come as no surprise. It's been shown in many domains outside of simulation as well. But the one thing that we sometimes see is that a lot of time and planning is put into developing the scenarios and actually running them. And then the feedback provision kind of comes as a quick add-on at the end. What we maintain is that you have to plan in advance for how the feedback is going to be provided in your simulation activities. In some cases, there can be feedback that's delivered from the simulator. CPR mannequin will give feedback immediately as to the depth of compressions, the rate, and so forth. More often, however, it's not built in, and we need one of our instructors or some other trained person to provide the feedback in the form of a debriefing. There's a lot of ongoing research related to, well, when's the best timing for the debriefing? Should that be during the scenario, after the scenario? How much time should be spent? And all of those are good research questions that are still being worked out. The bottom line is, though, that feedback must be given if we want to realize positive learning. So how can we put all of these features and uses of simulation together? Well, I find myself asking several questions, which I think are important to answer. You might be saying, okay, there's all these features, but does it work? Well, yes, the evidence is there. If you recall, I said that the inclusion criteria for our systematic review was that they actually had to show that learning happened. And there are many other reviews and meta-analyses that show that, on balance, simulation does work. But it's important in how do we use the simulation. And these are the features that we've been talking about during this session. Also, you have to ask yourself, what is the goal? What are we trying to achieve? For some people, it's a competency assessment, right? But for other people, we may be saying, well, we actually want to achieve more than just minimal accepted standards, just competence. Maybe we're trying to achieve excellence. Again, I find myself going back to our mission statement. And if we want to really save lives, if we want to see the learning that happens in the simulation environment translate to the clinical world, I think we really need to be shooting for the stars. In other words, aiming for really training excellent clinicians, expert practitioners. And so then you might ask, well, how do we become an expert? Some of you may be familiar with this a model that Anders Ericsson, an educational psychologist, has posited for how to achieve and maintain expert performance. He calls this deliberate practice. And I think in this model, we can actually put together all of these beamy features that we've been describing to you. The deliberate practice model includes intense, repetitive practice in a very focused domain. So clearly the outcomes had to have been defined ahead of time. Then it's not just practice, rote practice sake. It's actually practice with some rigorous assessment that will enable us to provide meaningful feedback to the individuals so that they can correct any mistakes they've made and gradually over time improve their performance. Once some automaticity has been obtained at a certain level, then you don't want them to just plateau there. Then we don't, then we're just competent or maybe proficient. But if we want them to be expert, then we have to increase the level of difficulty in a controlled way over time. And that's how we can achieve those highest levels of performance. A related concept to deliberate practice is that of mastery learning. Up until now, our educational interventions have primarily been time-based. We say they have 4 hours in the simulation center. The time is what's fixed. What's variable is the outcome, how much learning actually happens, because we know, again, that different learners learn at different rates. Mastery learning turns that upside down and says what we fix is our expectations for what they're going to achieve. In this case, a mastery level of performance. The variable becomes the amount of practice or the time necessary to achieve that. And here you can see the mastery learning features. Again, you have to set what is your standard, what is your defined outcome. You do some baseline assessment to see where are they coming into this schema. Then you plan educational activities that allow them to repetitively practice their skills. You give them feedback. How are you doing versus the objectives that we're trying to achieve? And then keep assessing. They get to advance to the next level if they've mastered one skill. Otherwise, they continue their deliberate practice until mastery is achieved. And to show you, to answer that question, does this work? Well, this reference here is a systematic review that showed that in simulation-based mastery learning interventions, you can actually not just learn in the skills lab, but there are translational outcomes. They actually improved physician or provider practice in the real clinical world and patient outcomes. So very powerful, these concepts of deliberate practice and mastery learning. If we look at our BME features one last time, we'll see that very many of them are features of deliberate practice. And many more of them are also included in the mastery learning concept. So I think these are the ways, through deliberate practice and mastery learning based interventions, this is how we can incorporate these evidence-based features into our simulation activities. So I hope that we've accomplished our learning objectives there. We've come to the point where we have about 7 minutes left in our time together. We're going to try to answer some questions right now. If you don't have your questions answered, we do see some in our Q&A window that we'll try to address. But anything that you think of after, here are our email contacts. Please don't hesitate to reach out to us afterwards. Another way that you can be in contact with us, for those of you who are going on to the IMSH meeting, the International Meeting of Simulation in Healthcare. It's going to be January over the Martin Luther King holiday weekend in Los Angeles. We will have a large exhibition there. Please come up to us and introduce yourselves and ask any questions that you may have. And lastly, our website is a good source of information. If you didn't get our email addresses, you can contact us via links at our website. If you happen to be in Miami, we'd also welcome anyone to come and visit us here. So now we're going to go to our Q&A. And let's try to answer some of the questions that we have from the audience. Has there been research done to measure differences in learning outcomes using different methods of teaching, didactic versus simulation, real patient versus simulator? I guess as a general concept, one thing I would say is you have to be cautious about what we refer to as media comparative type of questions. So you're asking us to compare almost apples and oranges by saying simulator versus something else, or didactics versus simulator. And that was specifically what they wanted to avoid when they posed the question to us from the BME executive. Because you can have an excellent lecturer who can achieve really good positive learning outcomes just from straight didactic type of things. Similarly, e-learning programs can have, if they're well designed, well implemented, they can achieve good educational outcomes. But you're really comparing apples and oranges if you then want to compare that to simulation. You could have somebody who doesn't use our BME features in their simulation activities and don't achieve their outcomes. They might have a negative result. So more important than to try to compare between different media within education is to look and see within simulation, what are those features or uses that will lead to the best outcomes? And that's what we try to elucidate in the BME review and some of the subsequent work like the AMI guide that we put forward. So I hope I've answered that question. We have one about how much do you do with interdisciplinary learning? How do you blend programs for the different disciplines? This is a hot topic, interprofessional education. Yeah. Hector's been very involved with some of the activities that we've done here. Maybe you'd like to speak about those.
So some of the activities that we've done personally is, one, we've had our Transitions to Residency course in which medical students are going from their 4th year of medicine to be now a 1st year in their postgraduate training program or interns in any of their specialties of their choice. So what we do in that course is on the first day of the course as interprofessional training, we do in the afternoon team training sessions where we go over the basic concepts of communication, so on and so forth. And we look at all these and then put them all in scenarios where they actually work together in teams and with nursing and medical students, and are either put into clinical teaching scenarios or skills scenarios or skills training scenarios. Clinical skills scenarios, a lot of times we'll have, for example, a post-cath patient that has a hemorrhagic bleed through the cath side in the right femoral. Or another example is a cardiac arrest patient that they have to respond to for the skills scenarios. And skills training will do multiple types of team training exercises. And one example of that is we'll use a crossover checkboard where they'll have to work in teams to cross over to the other side. Others are helium sticks, for example. It's a common example. You can Google and you can see some of these there, where they actually have to try to put a stick all the way down by communicating, creating leadership, and other examples of that. Other forms of interdisciplinary training that we've commonly done at the university-wide, we have our interprofessional training week or patient safety week that we do with the 3rd-year medical students and the nursing students, where we, for a whole week, they're working together and we're putting them through different types of skills, scenarios, exercises, and team building exercises as well. Other examples of interprofessional training that we've done here at the center are our different types of courses that we created, particularly our airway courses, acute coronary syndromes courses, advanced stroke life support. Well, we'll have commonly in all these courses different healthcare providers like nursing, physicians, depending on the course, paramedics, firefighters attending. And then when it comes to different portions in that training, they will be separated into a hospital section, for example, and a pre-hospital section for advanced stroke life support example. Acute coronary syndromes, an example of that is we have actually scenarios where the pre-hospital will attend to a patient with an acute coronary syndrome, identify the patient has an inferior myocardial infarction, provide the initial care of the patient in the back of the rescue unit, and then call in to the emergency department where there'll be a group of nurses and physicians awaiting to be able to get the transfer of that patient in the hospital and continue their care. So those are just some examples of different things that we've done. In addition, the list is pretty big. I think we've been doing a couple of different things in different areas. Another one's emergency response to terrorism with pre-hospital, hospital-based personnel, law enforcement training as well.
And there's a question from someone regarding DPT, Doctor of Physical Therapy programs. So recently in our patient safety course that we do with our rising third-year medical students, so they're just starting their clinical rotations in the hospital, we do that with end of second year nursing students who already have some clinical experience. And just this past year, for the first time, we incorporated some physical therapy students as well. And we did some interdisciplinary, interprofessional type of simulation. So that work is definitely being done. Lots of questions coming in. I'm going to go to some that have been here from very early on during the webinar about the suggested ratio of clinical hours versus simulation for a nursing program. Some of you may be aware there was a large study done, multi-center study, sponsored by the Federation of State Boards of Nursing and the NLN, which tried to answer that question. And they had a range of different nursing programs, from more community-based practice settings to tertiary care centers, large city versus a little bit more rural, a geographic distribution across the United States. This is only in the US that this study was done. But then they followed, and they had different percentages of simulation trainings in their curricula to substitute for clinical time. Then they tried to follow those nurses into their first jobs, and they used their work evaluations and different indicators to try to gauge the quality of their preparedness. What the study suggested, we could get into big discussions about the methodological challenges in doing a study like that, but the answer to the question that they come up with, up to 50% of clinical time might be substituted in the simulation setting. We realize that that's a big challenge for nursing programs. They're vying for real patients as learning opportunities with all the other health professions learners that are in hospitals these days. And so this is a big question. Different states have implemented different standards for what they will accept for licensure in their states, how much of the training could have been done with simulation. I would venture to say that very few places are allowing half of it to be simulation, but I've seen 10, 20% of clinical time being allowed now to be in the simulated setting. And again, that big study was probably the main reference to date that answers that question.
You wanna, this one here?
Also want to run mock codes using simulation with the care team. Docs never have enough time, but the process doesn't really work without them. How do I engage them in the process? That's a great question. This gets to the idea of, I think, simulation not only being integrated in individual curricula, so in the nursing programs or in the professional staff, continuing professional development program in your hospital, but it has to be embraced by the system, by our culture. We're slowly getting there. In simulation in health professions, we often point to aviation as the model we're trying to emulate. There, everybody participates, and if you ask a pilot, a flight attendant, a ground personnel, an air traffic controller, no one can think of the system running without simulation being part of it. We're not quite there yet in simulation. I think we are slowly moving in that direction. If you get buy-in from the executive leadership of your hospital, that may be the easiest way. Sometimes you need the stick if the carrots aren't sweet enough to draw them into participation. More and more places are giving incentives, for example, discounts on malpractice insurance if you participate in training activities involving simulation that address high-risk events that happen in your hospital and so forth. So there are different ways. It would be a long answer to try to fully answer your question, but we realize that this is a challenge in some places, but more and more people are getting it. And I think we're going to see increasing buy-in as we have this diffusion of innovation curve where we're at the maybe the late adopters phase already. And so only those laggards will kind of have to pull into our simulation training. I'm looking at the clock, and I think we're probably going to have to cut off our questions here. There are many that are unanswered. I apologize for that. Our email address, hopefully you got that. Please email us your questions and we'll attempt to answer those after the fact. We will also include our email in the link that you will get. One of the questions is, will your presentation and webinar be available to view again? Yes. So if you missed the announcement at the beginning, about sometime next week, you will get a link that will give you access to the webinar that you can review again. And then it'll also include our email addresses for contact information at that time. So thank you again so much for being with us. We hope this proved useful. There will also be an evaluation form that will be part of the follow-up email. We encourage you, please give us some feedback. That's the only way that we learn. Thank you so much.
Thank you, everybody.
And take care.